for dosing. Use epidural kit if no specific kit is available. Pediatric epidural catheter is 24 gauge, which goes through a 20 gauge needle. Remember the dead space. The catheter and the filter in the epidural catheter is about 1 ml. And for PDPH prevention, leave the catheter behind for 24 hours and injecting saline before removal of the catheter. Well, again, it is a conflicting issue. Most important is the clear identification and instructions of who manipulates the catheter. This is the technique, how you do it, just like a spinal you use without the LOR technique. You go straight like a spinal, enter the subarachnoid space. There's a small video which will show you how it is done. This is just like a spinal needle, you go inside. The moment you get CSF, you put back the stellate or cover it with a thumb to minimize the CSF loss. And then insert the catheter.
Ask the patient.
Hold it in place and bring out the needle. See that the measurement is proper. The catheter tip is 2 to 3 centimeters inside the subarachnoid space. And this can be confirmed by the gravity test, holding the catheter down. Now, which drugs can be used for combined spinal continuous spinal anesthesia? Any drug which has safely been used for routine spinal, any additive which has safely been used in routine spinal, the use of isobaric local anesthetic versus hyperbaric local anesthetic, you can choose judiciously as per the case requirement, either solely or in combination. Start with very low volume, which can be easily titrated. And remember, consider the dead space volume of epidural catheter and filter, which is about 1 ml. What are the advantages of isobaric local anesthetic? It is not position dependent for intrathecal spread and visualized with good results. Surgeries requiring patient to be positioned laterally without affecting the local anesthetic spread. There's remarkable cardiovascular stability, even with high levels of block. Low dose block, sensory more than motor, giving selective segmental spinal. Onset is gradual as in epidural. It preserves the muscle tone, power, and recovery of the muscle tone is faster, hence useful in early mobilization. There is less sympathetic blockage, less chances of DVT, and early bladder control. Now coming to the complications. Most are same. Spinal anesthesia like infection, hematoma, and neurological. Koda-Equina syndrome, which was noted much earlier in practice, is not reported in recent times. And the most expected is PDPH, which can be minimized. This is just to show the different studies showing the complication rates, which are varying from 1% to almost 9% for PDPH, and it all depends on the catheter gauge used and the drug which is used. There are a few cases of breakage of catheter also, which are microcatheters. The catheters are broken also. Now, regarding Koda-Equina syndrome, the Regular et al. In 1991 reported 4 cases. The theories which were postulated were maybe the microcatheters, which led to the FDA ban in the US, and the use of 5% hyperbaric lignocaine. Arkush et al. And Lux et al. In 2008 and 2012 came out with studies which didn't show any evidence of Koda-Equina syndrome, and they were instrumental in getting the ban revoked. PDPH, to minimize PDPH, again, microcatheters came in picture. Bizarre et al. In 1964, Curley et al. In 1990 used a 32 gauge catheter passed to a 26 gauge spinal lead. But again, as I've mentioned before, smaller catheters have got their own limitations and complications. Now, what about post-dural puncture headache? This can be minimized. What we can do is, this is for the safety thing also I'm saying, if you see there is a knot, once you finish the surgery, I knot the catheter twice, label it with a spinal catheter, and keep it for 24 hours. Removing of the catheter after 24 hours causes the dural edema which is there to collapse over the puncture and minimize the CSF leak, thus reducing the chance of PDPH. And in whatever more than 200, 300 cases I must have done, there has hardly been any occurrence of PDPH as reported by the patient or the treating surgeon. I specifically asked them to look for PDPH, and there has been no significant case of PDPH reported in my cases. So what are the take-home messages? Proper patient selection, proper patient counseling, quantification of expected time of surgery, surgeon's acceptance, availability of all basic monitoring equipment and proper anesthesia workstation, patients who are unwilling to undergo GA, patients at high risk of perioperative morbidity and mortality with GA, older patients who are low in physiological reserves with multiple comorbidities in whom general anesthesia will invite polypharmacy, cognitive dysfunction, and other complications. And lastly, continuous spinal anesthesia should not be an option to cover non-availability of basic monitoring requirements or as a cost-cutting procedure. Finally, these are a few literatures which are there available on the internet to support continuous spinal anesthesia regarding and different references which are available. So thank you. I finished my talk. Thank you very much. Thanks you.
Thank you, sir. Thank you for such a wonderful presentation. You have explained this complicated and less known topic, not newer. First of all, we thought of that topic is newer, but that topic is not new, but regardingly unknown. But you have simply enlightened us with this continuous spinal anesthesia. Some questions are there, sir. So I would like to ask you that is there any specific change of consent which we will take during before putting this continuous spinal anesthesia? Is there any change in specific?
Good question, especially in today's times. I think, as I mentioned in the take-home messages, counseling the patient and informing about what you're doing. Whenever you do something out of the box, I think the patients and the relatives are to be counseled, are to be told about the risk versus benefit ratio, and explain them, and then taken a proper consent. Definitely, yes. There is, I don't think there is a fixed consent, but we do take it in writing on paper that this is will be done in this by this technique, which is similar to spinal anesthesia, just an extension of that. And we explain the relatives and most of them agree.
Okay, okay. And
Tushar, there are two more questions in the chat box.
Yes,
You can take up.
yes. Miss Smita Kulkarni ma'am has asked, how many cases you did, sir, with the continuous spinal anesthesia?
In the last 4 years or 5 years, maybe about 300 plus cases.
That's great.
I see. I'll tell you, it's not a routine procedure you should do. As I said, you should have selective cases for
that
this.
is a great number.
Yeah. Selective cases where you can justify what you're doing. As I said, it is not like something to be done for a cost cutting or you should justify the technique for what you're doing. So for in 5 years, near about 300 cases.
Tushar, one more question is there in the chat box.
And
ho-
I already said choice of drug for continuous spinal. Uh, Again, 2 years back, we didn't have a choice. We had to do it with our regular analogy. But now with availability of our isobaric preparation, we can have the combination advantage of both, advantage of continuous spinal and the advantage of the drug. So as it is, continuous spinal gives you good hemodynamic stability. So added to it, if you are using an isobaric preparation, definitely it helps. But again, you should use it judiciously where it is required. Like even in thoracic segmental spinal, we do use a combination. You do a very small amount of hyperbaric first, and then you go for a isobaric preparation. So it should be a judicious use of drug which is available. Recently, this new drug has come. I just last week I used it for continuous spinal, ropivacaine heavy. That is also a good molecule. I use it only one case, but let's see how to confirm catheter direction.
Seema?
Oral direction.
Yes, ma'am.
Hello.
Okay.
Seema, Tushar is, he got disconnected. You can ask the questions. There are 3-4
Yeah.
questions in the chat
Yeah,
box.
sir is
Yeah.
already reading it. How to confirm the catheter
Yeah.
direction? Yeah.
See, the bevel of the to his needle has to be pointed up. Okay. And then you go, as I said, I don't go beyond 2 to 3 centimeters. But again, confirmation, there is no fixed test for confirmation of the direction of the catheter. We intend to go cephalad, but maybe as current is there, whatever, there is a chance that it may go. But then with proper use and proper dose, you can always titrate your doses to get adequate levels.
Sir, I think there are many questions
Huh.
for you, sir.
How do you flush out the? I don't do it. I don't do it. As I said, it is mentioned that you aspirate CSF into that. What I do is I prime the catheter with local anesthetic drug, and then I insert it. Okay.
Okay.
So 1 ml of the drug is already there. In my syringe, if I've got 4 ml of, I take a complete dose. I don't change the needle and the syringe again and again to avoid contamination. I just fix it there. And then once you have primed it, you have got 3 ml in your syringe. Then you measure it. You go half cc or 1 cc. So instead of drawing CSF into the set, I prime it with the local anesthetic solution. And in the end, again, there is no reason to flush it. You just knot it and keep it there. Because next day, 24 hours later, you're going to remove it. What are the doses? As I said, I start with 0.75 to 1 ml. And subsequently, requirement is at 45 minutes. It's like just like you're giving your muscle relaxant, when you're doing GA. Every half an hour, 45 minutes, you tend to do a Trasil or cisatracurium depending on the patient coming out. It is something like that. PDPH incidence, as I said, in whatever cases I've done, very minimal. Is there any troubleshooting management for in failed CSA? Good question. Whatever is there, then is general anesthesia, I feel, or abandon the procedure if possible. Yeah, ropivacaine, I said, I've used ropivacaine in one case, ropivacaine heavy, which is there. Intrathecally, I've used isobaric preparation of levoanavir. Ropivacaine isobaric I have not used so far, but levoanavir in many cases. How do you time the top up? Again, as per the patient's condition. Patient has pain or there is everything is fine, and the top up is just half cc.
Sir,
Chances of slippage of catheter from the space, that chance is always there unless you fix it properly. I don't think. Intrathecal ropivacaine, which is available now, I think whatever ropivacaine is available in the market is FDA approved for intrathecal use. They have come out with intrathecal hyperbaric ropivacaine, so it's already there. Any more questions?
Sir, we are using ropivacaine as in spinal anesthesia also, routine spinal anesthesia. So what problems we are facing that during abdominal surgeries, you also mentioned in your lecture that there is good pain relief, but there is limitations of some muscle relaxation.
Yes. Yes.
But what is there any adjuvant you use for that muscle relaxation in abdominal surgery specifically?
In abdominal surgeries or in orthopedic surgeries, I always use an adjuvant. I always, and my either I go for a fentanyl or buprenorphine or clonidine, depending on the case. So commonly it is either fentanyl or buprenorphine.
Okay.
At what level would you place a catheter for isobaric drug? That Dr. Naresh Paliwal is going to speak in some time, depending on the level of surgery which is required.
Can I add
It's
something?
There are
difficult
two
to
more
manage the
questions, I
catheter
think.
after shifting the patient in the room. No. If you have fixed the catheter well and given a good dressing on it, tight dressing, there is it is just like an epidural catheter. Only care which you have to take is there is no accidental inadvertent injections through that, considering it is an epidural catheter. I've seen epidural infusion going IV in many places in spite of labeling. So that care you have to take. So it is like, who is going to manage that catheter? You are going to see that catheter removed next day.
There is one colleague has raised a hand. He wants to ask a question. iPhone. The name is not displayed there.
And that is Dr.
Yes, sir.
Kamdar, sir.
Yes,
Kamdar, sir, yeah.
yes.
It's a Kamdar,
No,
sir. Okay.
Dr. Rao, I have been seeing you giving segmental spinal, and you usually go in the lower thoracic level. But since you are going to pass the catheter and the catheter is going to be inside for 2-3 centimeters, do you go at a lower level to give continuous spinal, or you still give at higher level?
I will go one level. I will go at T10 level, sir. T10. See, it is up to me then how much to direct the catheter inside. Instead of 2 centimeters, I can go to 3 centimeters also.
Thank you. Thank you.
So I think chat box is clear now, and all the delegates have cleared their doubts. One question has came there. For relaxation, best is xylocaine, then bupivacaine, then ropivacaine.
Xylocaine is no
That's
more
the best
available.
suggestion. So thank you, sir. Thank you for your
Tushar, you are not audible. Is there any problem?
Can I add
Hello?
few things?
hello.
Hello.
Yes, sir, Paliwal, sir.
Hello. Is it audible?
Yeah, it is audible. Yeah.
Paliwal, sir, you are saying something.
Yeah.
Yeah.
I am also.
I think all
I
the
also- Okay. Hello.
Sir, you can continue.
Paliwal sir, you please continue.
I am also using this continuous spinal since many years, and there are few things I would like to add. When you are not able to put the catheter inside, and if you want to remove the catheter, remove it along with the needle. Don't remove it only catheter. That can shear the catheter and can, piece of catheter remain inside the intrathecal space.
Right, sir.
And the other thing is you can also use hypobaric drugs along with this. According to your choice, this is also a good drug for continuous spinal anesthesia. And to the question Tushar asked about the failure of relaxation and all, under opioid and heavy. So many times what happens is we test for some one sensation like pinprick or touch sensation, and the other sensations are also there like spatial summation and temporal summations, which are not lost during epidurals. They are better lost with continuous spinal. So these are the sensations lost with dense blocks. The temporal summation is responses from the adjacent structures, and the spatial summation also is there. So these things have to be blocked. If these are not blocked, then the patient may have some issues like inadequate relaxation, or we only test for touch sensation and at times pinprick sensation. Very good presentation by Dr. Rajesh Rao.
Thank you,
Okay.
sir.
So thank you, sir. Thank you for your precious time for such a good topic. Now I would like to invite our next speaker on the topic of segmental spinal anesthesia. Respected Dr. Naresh Rao, sir.
Naresh Paliwal. Dr. Naresh Paliwal, sir.
Dr. Naresh Paliwal, sir. He is associate professor at Dr. PDMC Amravati Hospital, faculty at various state and national conferences. He has various publications on segmental spinal and DEX kit, that is dexmedetomidine and ketamine combination in pediatric patient. He has best paper award at ISACON Maha Nagpur. He has made plenty of paper publications on segmental spinal anesthesia nationally and internationally. He was also one of the speaker in international conferences. He also very active on social platform, through which he always open to share his knowledge and clear doubts of all ISA members. So I request sir to start with his presentation.
Hello, good evening, everyone. At the outset, I'm very much thankful to ISA Pimpri Chinchwad, especially Dr. Maya Bhalerao madam and Seema Suryavanshi madam for inviting me, and also thankful to Dr. Rajesh for a wonderful presentation. By now, everyone has been well acquainted with my segmental spinal thing, but just a minute. I'll just go quickly through this, my presentation, to have enough time for question and answer session. Now, something about the history. It was in 2006, the new era on segmental spinal began when Evan Zundert gave spinal at T10 for laparoscopic cholecystectomy in a patient with severe COPD. Since then, there have been many studies, but recently during this COVID time, it has taken up a boom, and it has become a most trending regional anesthesia technique. Many people have started using it. Now, what is segmental spinal? The segmental spinal is term often used synonymously with the thoracic spinal, but even the low doses of the drugs used at a high number levels can have a segmental effect with sacral sparing. So the ideal definition is blocking of the required dermatomes, essential for the proposed surgical procedure with a very low volume of local anesthetic drugs near the targeted nerve roots. This often necessitates dural puncture at the high lumbar or low thoracic level, mid-thoracic levels. Lower the volume or the dose of the drugs used, more likely to be a true segmental block. Otherwise, it can spread to other segments. Now, there are some factors which make segmental spinal feasible. In thoracic segments, the spinal cord is positioned anteriorly. There is a significant space between posterior and spinal cord. The thoracic nerve roots are very slight and thin. They are easily blocked with a low volume of drugs. The amount of CSF at thoracic levels is comparatively very less. There is no difference in the onset time for isobaric and hyperbaric drugs at thoracic levels. So what we find is isobaric drugs, they usually take some time for onset, at lumbar levels. And there is natural thoracic kyphosis at thoracic levels. There are some septic concerns whenever we talk about segmental spinal. The first and foremost is neurological injury with dural puncture at mid to lower thoracic or high lumbar levels. Second is ventilatory impairment due to extensive thoracic nerve blocks. And third is bradycardia hypotension due to blocking of cardiociliary fibers and high spinal. And last but not the least is medical legal issues, as it is still to appear in the standard textbooks. The major concern is damage to spinal cord. A midline MRI of the spinal column. Here you can see there is significant space between the posterior dura and the spinal cord at mid-thoracic levels. This is a magnified view. Here you can see clearly. This is the position of spinal cord at various levels, thoracic, thoracolumbar, and cauda inguinal levels. Imbeloni and Gouveia did a study on the low incidence of neurological complications during thoracic epidurals, and they measured the exact distance at various levels, T2, T5, and T10, and they found the distance to be around 5.19 millimeter at T2, 7.75 millimeter at T5 level, and 5.88 millimeters at T10 level, a distance sufficient enough to introduce a spinal needle. Then again, Lee R. did a study on the anatomy of thoracic spinal canal in different positions, and they found the distance to be more in all positions, especially the lateral and sitting positions. These are the positions we usually use for giving spinal. The distance is more in these positions at mid-thoracic levels. The spinal cord is placed ventrally in the apex of the thoracic curve. The left-hand side figure shows the distance between the anterior dura and the spinal cord, and the right-hand side figure shows a distance between posterior dura and the spinal cord. You can see there is a lot of distance from the posterior dura to the spinal cord. This is again a midline MRI. Because of the angulation, which is required to perform a spinal anesthesia at mid-thoracic levels, you need to have an angulation almost 40 to 45 degrees to perform a spinal at mid-thoracic levels. The distance between posterior dura and the spinal cord is further increased. You can see here the distance is almost 8 millimeters as compared to 4.5 millimeters at lower thoracic level. Spinal, the incidence of neurological injuries after accidental dural puncture during thoracic epidural is found to be very less. And many anesthesiologists unknowingly use high lumbar or thoracic spaces for giving spinal, especially in the obese and parturients. And the level at which the spinal cord terminates is also variable. The second issue we often raised is ventilatory impairment. Here, the main inspiratory muscle of respiration is diaphragm, which is usually unaffected. Expiration at rest is a passive process. Forceful expiration and coughing may get affected due to paralysis of anterior abdominal wall muscles. The low doses of the drugs used usually preserve coughing ability due to minimal motor weakness of abdominal muscles. About the bradycardia and hypotension, the heart rate may decrease if block extends T1, T4, but due to lumbosacral sparing, the reverse vein bridge reflex is usually not activated. And due to lumbosacral sparing and less venodilatation in lower limbs, the atrial filling is maintained, and that usually sustains the outflow from intrinsic chronotropic receptors, which maintains the heart rate. And the less hypotension is usually the less sympathetic blockade because of the low doses of drugs. The most important thing, medical legal issues and litigation. Now there is enough evidence to prove its utility in cases where it is most indicated. This was the most indicated thing during this COVID times when we wanted to avoid the general anesthesia. The most cases of litigation are against regional anesthesia, but still the thoracic epidural is being performed day in and day out, even with accidental dural puncture occurring in many cases. Proper explanation and consent is must. It started to appear in some textbooks. Till that time, we should keep our fingers crossed. The feasibility of segmental spinal and utility. Technically, it's not much difficult with due precautions. Economic, it's very, very economic. Legal feasibility is still a question mark, but can be defended with strong indications. operational feasibility for experienced clinicians with good learning curve. It is very much feasible. It can be used for practically all abdominal surgeries, whether it is upper, lower, open, laparoscopic, major, minor, even for breast and superficial thoracic and some thoracoscopic surgeries, and some prone and lateral position and musculoskeletal surgeries. There are some advantages of routine spinal and at times for general anesthesia. Surgery is thought to be out of domain of spinal anesthesia or possible with segmental spinal, like upper abdominal, thoracic, and breast surgeries. High levels of the block can be achieved with just half the dose that is required at lumbar levels. There is minimal hemodynamic fluctuations, early recovery and voiding. Special advantages or general anesthesia in patients with respiratory comorbidities and can avoid post-op pulmonary complications and ventilatory support in such cases. There is also lower incidence of PONV. There are different modes of using segmental spinal. Either it can be a single shot segmental spinal for short to mid duration surgeries up to 120 minutes, or it can be combined with epidurals, either for long duration surgeries or in very morbid ill patients when you want to use very low doses for segmental spinal. In that case, the epidural can be handy not only as a backup, but by epidural volume extension technique, you can spread the low doses of intrathecal drugs to wider segments. And the epidurals can also be useful for post-op analgesias. There is third option, that is continuous segmental spinal anesthesia, just like continuous spinal anesthesia, using spinocats, giving titrated and sequential boluses in very morbid ill patients. Or when you have accidental neuropuncture during thoracic epidurals, you can convert it to continuous segmental spinal anesthesia. About the drug options, isobaric, hyperbaric, either of them can be used. Even a combination of hyperbaric and isobaric can be used in some abdominopelvic surgeries. In general, isobaric drugs are preferred for laparoscopic, thoracoscopy, breast and superficial abdominal or major intra-abdominal surgeries in very morbid ill frail patients where relaxation is not an issue. And hyperbaric drugs can be a choice in male muscular patients. Some advantages of isobaric drugs already covered by Dr. Rajesh. These are the preferred drugs as they are less sensitive to position issues. They have a selective block, onset is gradual, hemodynamic stability even with higher levels of block. Motor block time is shorter, leading to early ambulation avoiding. Spinal can be given directly in the operative positions, like in some lateral position surgeries, ortho surgeries, or kidney surgery. Or patients can turn on his own immediately after spinal to desired positions, like in prone position spine surgeries. And spinal can be given before epidural and at a space higher than epidural without worrying for unilateral effects, which can happen when we use hyperbaric drugs. There are some disadvantages of isobaric drugs. The levels of block cannot be modified by any change of positions. The drugs need to be placed at a precise dermatomes. Like in epidurals, sacral sparing is common when low doses at higher spaces are used. They take some time for onset at lumbar levels. Slightly less muscle relaxation, so we need higher doses in some male muscular patients. And they are also sensitive to temperature variations and at times can have unpredictable results. Amongst the available drugs, isobaric drugs like chlorprocaine 1%, which is now not available, leobupivacaine 0.5%, ropivacaine 0.5 and 0.75%. Hyperbaric drugs like bupivacaine 0.5 and now ropivacaine 0.75% can all be used. Chlorprocaine 1%, which was a very good drug, but now they have discontinued because of not many people using it. It was very useful for very short duration procedures, 40 to 60 minutes. About the leobupivacaine and ropivacaine, leobupivacaine 0.5% and ropivacaine 0.75% are comparable. Ropivacaine, being less lipid soluble, is nearly half as potent as leobupivacaine intrathecally. There is a stronger differentiation between sensory and motor blocks with ropivacaine. Addition of small doses of additives like fentanyl, dexmedetomidine, ketamine, or clonidine can intensify the sensory blocks. Dexmedetomidine usually provides longer duration than others in a dose-dependent manner, like 10 mcg can give you a block time of more than 3 hours. And ketamine, though potentiating sensory blocks, is known to shorten the motor block time. BPOA can heavy 0.5% and ROPOA can heavy 0.75% can be used in the same dose range as isobaric drugs. Thoracic segmental anesthesia can be produced with just half the dose that is used at lumbar levels. Onset time is reduced to reach T3 levels. Gravity dependent spread has to be kept in mind. Can be a better choice for open surgeries in muscular patients. How to decide about the dose and the site of injection? How to decide about the dose and site of injection for abdominal surgeries? It depends on the type of surgery, whether it is open or lap, there is upper or lower abdominal surgery, average duration of surgery, what are the comorbidities of the patient, and whether combined with epidural or not. Dose of local anesthetic and the site of injection along the near axis can be varied. If you keep this in mind that 1 ml of isobaric drug spreads 2 to 3 segments above and below the site of injection, you can calculate the doses required for each surgery. What this means is 2 to 2.5 ml the drug is sufficient to block segments from T2 to L5S1 if spinal is given at T10. 10 thoracic space lying in the center of the surgical field for upper abdominal surgeries. Dose and site of injection. With adequate dose, space about T10 is hardly required for abdominal surgeries. Space between T10 L1 and a dose of 2 to 2.5 ml with some additive is sufficiently for 90 to 120 minutes. There is a regression of effect from lumbosacral roots. It starts wearing after 70 to 80 minutes, and for surgeries involving pelvic manipulations, if you anticipate that beforehand, going beyond this time, then you can use a combination of hyperbaric and isobaric drugs to prolong the effects at lumbosacral roots even up to 2 hours or more. For breast and superficial thoracic surgeries, spinal at mid-thoracic levels is usually preferred, T456, with 1.2 to 1.5 ml and some additive. But even up to 2 ml can be used if lower spaces are used for spinal. That will spread the levels unnecessarily. So mid-thoracic levels are usually preferred. With this much dose, it can provide a duration of 60 to 90 minutes or a little more if dexmedetomidine is used as additive. For prolonged procedures, it is always better to combine with epidurals or some blocks rather than increasing the intrathecal dose to avoid the undue respiratory and cardiac events. These are some levels required for breast surgeries. Like for MRM, you need levels from C5 to T7. For mastectomy with transverse rectus abdominis flap, you need levels from C5 to L1. And for partial mastectomy or breast augmentation, just T1 to T7. And the epidural scoring scale for arm movements, which is used for epidural assessment of the epidural, can well be used for segmental spinal at mid-thoracic levels. The 0 to 3 gates, hand grip T1 C8, wrist flexion C8 C7, elbow flexion C5 C6. Position of the patient using isobaric drugs does not matter. Either or any position can be used. Plain buccal 0.5% is slightly on a hypobaric side. And if you give in a sitting position and patient kept seated for some time, can lead to some high levels of block. Temperature of the drug has inverse relation with baricity, especially with the isobaric drugs. Cooled at 24 degrees, a density of 1.0032, it becomes slightly hyperbaric, and warmed at 37 degrees, it can become slightly hypobaric. So wide variations in temperatures can have some impact on gravity, impact of gravity on the spread of drugs. Using combination of hyperbaric and isobaric drugs, sitting position is mandatory initially for giving spinal. Type of needle, either Quincke or pencil point can be used. Combined with epidural, CSC kit is the easiest and safest option. Pencil point needles have more chances of paresthesia as you need to enter more in the intrathecal space with pencil point needles to get a free flow of CSF. Now, how to identify the landmarks? It can be either manual or by those who have the facilities of ultrasound, they can use ultrasound. There's prominent spinous process of C7. Root of the spine of the scapula corresponds with T3. Inferior angle of the scapula corresponds with T7. Using ultrasound, you can count upwards from L5S1 in parasagittal oblique view or you can identify the 12th rib and count upwards, or identify first rib and count downwards. There's some anatomical hurdles for thoracic spinal. Thoracic spinal processes are sharply angled and point caudally between T4 to T9. Beyond T10, they resemble those in the lumbar region. Beyond T10, the spinal is as your other lumbar spinal. It is as easy as that. Interlaminar spaces in the thoracic spine are narrow and more challenging to access with a midline approach. So a paramedian approach can be tried for mid-thoracic spinals. These are a few tips for giving spinal by a paramedian approach at thoracic levels. Ultrasound imaging can be used, but there is very small window in parasagittal oblique view at mid-thoracic levels, and there is usually no window in transverse view. I'm just learning to use this modality for thoracic spaces, but it's not as easy as your lumbar spinal. What ultrasound tells us is the location of interlaminar space, depth to interlaminar space, midline, and which side to use, especially in scoliosis. The convex side is more open, can be located with ultrasound. The parasagittal oblique view at mid-thoracic spine is usually used to locate the ligamentum flavum dorsal dura complex, that is LFD complex. A transverse interspinous view at mid-thoracic levels is usually of no use. Safety measures for successful use of segmental spinal. Preoperative assessment, type and site of surgery, approximate duration of surgery, dermatomes involved in the proposed surgery. You should know beforehand what are the dermatomes. If ultrasound facilities are available, your pre-procedure scan can be done. Identification of the landmarks to locate the interval space for giving spinal. Selection of proper drug and mode of segmental spinal, whether you want to use a single shot segmental spinal or you want to use a epidural along with that. Decision on to the site of injection and doses of the drugs required. Assessment of levels after giving spinal, then monitoring and use of appropriate sedation as per need. In the preoperative assessment, apart from site of surgery and type of surgery, you should know beforehand the duration of surgery. Just a minute. Whether it is a short duration, mid duration surgery, or a long duration surgery. Comorbidities of the patient. As to the feasibility of segmental spinal, excuse me, I'll just call you afterwards. Comorbidities of the patient. As to the feasibility of segmental spinal with the minimum possible dose and combined with epidural or as a continuous segmental spinal anesthesia using spinocats. This is a slide showing the dermatomes which we have to know, which are involved in the proposed surgery. Like I already told you, for breast surgery, you need to block from C5 to T7. Now coming to my segmental spinal profile, more than 3,000 surgeries initially used for high-risk cases, but now usually occupies nearly 50% of my SAV profile. Very few partial failures, but no mishaps. Complete pre-anesthetic evaluation of the patient is done when a access, minimum mandatory monitoring, no sedatory pre-medications. I use lateral decubitus position for spinal and 27 gauge needle. Speed of injection is usually average, 1 ml per 15 seconds, depending on the patient's parameters. Physical hemodynamic, the site of surgery, dose of local anesthetic, and the site of injection is selected. For intra-abdominal procedures, for short duration procedures, I used to use chlorprocaine, but now it's not available. So I use either bupivacaine or ropivacaine. For mid-duration surgery, either For mid-duration surgeries, either leo-bupivacaine or ropivacaine 0.75% or bupivacaine 0.5% or ropivacaine heavy 0.75% with fentanyl, ketamine, dexamethasone. For average female patient, I use 2 ml plus additive, and for average male patients, 2.5 ml plus additive at usually T10 to L1 interspace, and combined with epidurals. Usually the initial dose is kept to the minimums, and I usually combine this segmental spinal with various blocks like transverse abdominis plane block, rectus sheath block, or erector spinae plane block for open surgeries, or local anesthesia at the port site for laparoscopic surgeries. For breast surgeries, leo-bupivacaine 0.5 or ropivacaine 0.75% is what I use along with fentanyl, ketamine, or dexamethasone at mid-thoracic levels, and usually combined with epidural or some blocks like PEC1, PEC2, serratus anterior plane block, or erector spinae plane block for post-op analgesias. This is two-drug technique, which I frequently use for procedures of abdominal pelvic surgeries like TLH, PCNL, colorectal surgeries, where you need to have a dense and assure effects at lumbosacral roots, which cannot be achieved with using low doses of diazepam drugs alone at thoracic levels. Even this can be used for some LSCS, gynec, or ortho surgeries. For this, you need to give spinal in sitting positions at T10 L1 space, 0.5 to ml of hyperbaric bupivacaine, followed by 1.5 to 2 ml of isobaric drug with some additive in different syringes. Initially hyperbaric drug and then isobaric drug. The patients usually turn supine immediately after the spinal or kept in lateral position with operative side up for lateral position surgeries. Sensory block is tested, which usually sets in 3 to 4 minutes. Some hemodynamic fluctuations can occur depending on the patient and dose in the first 10 minutes, but these are usually minimum and gradual. There is no respiratory embarrassment even with high thoracic or cervical root involvements usually, as mostly it is a sensory block. There is initial partial involvement of lumbosacral roots which can occur, which with high doses are used, but that usually recovers at the end of surgery. There are no additional supplements usually required in most cases, barring few lap surgeries where you may need some sedation. Patients can be completely mobilized in 4 to 6 hours. To sum up, it's a very useful technique with many advantages and minimal risk with due precautions. No need to panic even if the block level is found to be higher than desired. Lap surgeries may need little sedation and it should not be considered a failed block. When facilities are available, ultrasound can be helpful for more safety. Technique is usually reserved for experienced clinicians with good learning curve. Now I'll show some videos. This is a simple video of how I give spinal at lower thoracic, high lumbar levels. This is simple, probably umbilical hernia patient with a 27 gauge Quincke needle. Draping is avoided to have a clear view. Just 2 ml of the drug. Low thoracic spaces are as straight as your lower lumbar spaces, L2, L3, L4. This was a morbid obese patient, 132 kg, for a hysteroscopic removal of a polyp. Spinal was given in sitting position at T12 L1 level. Procedure was said to be going around 60 to 70 minutes, so spinal was preferred. This is the same lady during the procedures. She is after 1.5 hours shifted to recovery, and this is after 3.5 hours. She was completely mobilized. This is MRM being done under combined spinal and epidural. Spinal was given at T7-8 and epidural was at T6-7. This is how the levels are being tested, and you can see the patient, how comfortable she is even with such high levels of block. The sensation at T8 was not there, but the grip strength was good, indicating only a sensory block was there. This is MRM being done in the same patient. Whenever you forget to give some block or you're not using epidurals for mastectomies, you can ask the surgeon to give PEC1, PEC2 block under vision at the end of surgery. This is surgeon himself giving the block PEC1, PEC2 at the end of surgery for post-op analgesia after segmental spinal. This was a unique case which I did 4-5 years back. This was traumatic diaphragmatic hernia. You can see the whole of the left hemithorax is filled with intestines. This is diaphragmatic mesh repair being done, the same patient. This was done under combined spinal and epidural. Same patient at the end of surgery. Now he is ready to shift himself. The next X-ray of the same patient, full expansion of the left lobe open. This was obstructed umbilical hernia. You can see his respiration. It was done under combined spinal and epidural. Epidural being placed at T8-9, spinal at T9-10. There's a big transverse incision all over the abdomen. This is laparoscopic cholecystectomy in a morbid old lady, diabetes, hypertension, IHD, ETCO2 being monitored. This was a huge ovarian cyst thought to be a malignant. It was compressing all the intra-abdominal structures. It was more than almost 44 weeks of pregnancy, like just it was compressing all the intra-abdominal structures. It was done with 2-drug technique, 0.5 ml of the hyperbaric drug initially, and then 2 ml of the isobaric drug. In sitting position, the same patient immediately after the spinal. Her cyst had to be ruptured. It was such a huge cyst, even with a full length incision, you cannot remove it. Her cystectomy, omentectomy, and hysterectomy was performed. This is again MRM being done. Epidural is placed at T4-5, and spinal was not possible with midline approach, so it was given with paramedian approach. This is many people, many surgeons, they complain about the cautery issue. They are not comfortable under regionals. They say the cautery usually does not work under this, but if you lower the currents of the cautery, okay, it works very nicely. This is during axillary dissection using a bipolar cautery. This is the same patient at the end of surgery, shifting herself. This is TLH, laparoscopic hysterectomy, done under 2-drug technique. This is at the end of surgery. The patient complete regression of the power in the lower limbs. This was known case of CA vocal cord. Upper GI showed signs of near total occlusion in the post-recurred region. It was posted for feeding gastrostomy. Tracheostomy was already done. It was done with just 1.5 ml of the drug at T9-10 level. This is PCNL done under 2-drug technique. This is ruptured ectopic. You can see here the whole of the abdomen is filled with blood. The patient being interviewed during surgery. This was a patient, was a relative of a doctor with AAD with bacillary invagination. She had a limited mouth opening, and she also had disc bulges at C4-5-6 and some neurological issues at upper extremities. But she was very much worried about her neck movements. She used to get giddiness during her neck movements. and the C1, C2 fixation was already done. So I convinced her for a segmental spinal, and it was drug with two-drug technique. I did not touch her neck at all, except for putting a ETCO2 monitor. This was a colorectal anastomosis, which was done 5 days back. It was dehiscence of the colorectal anastomosis, and the patient had bilateral pneumonia. He was in sepsis after 5 days and had to reopen. The whole of the abdomen was filled with pus. You can see his pre-op hemodynamics. It was done with single shot segmental spinal. This was a ruptured liver abscess in a young lady of 21 years old with hemoglobin of just 4.9. Her counts were around 48,000 and CRP was raised. It was done with a single shot spinal, segmental spinal. You can see the thick pus below the. This is how I used to monitor ETCO2 when the probes for special monitoring of ETCO2 were not available. This is 12 gauge suction catheter. The tip is attached to the ETCO2 port and in the nostril. This is simple appendicectomy, laparoscopic appendicectomy, ETCO2 being monitored. Same patient at the end of surgery, shifting herself. This was a recent case of small intestinal volvulus because of this polyp which was surrounding it. It was done with heavy bupivacaine as the patient was young male and wanted to have a relaxation. Could be saved on time. It was getting little blackish. These are two patients being interviewed, one at the end of surgery and one during surgery. Let's see. She's so comfortable even with such high levels of block during lap surgeries. These are my few publications on segmental spinal. And thank you very much for patient listening. Thank you.
Thank you, sir,
Hello.
for. Hello.
Hello. Dr. Tushar.
I hope I was clear throughout.
Yes.
Yeah, you were absolutely clear. Dr. Tushar, can I ask him, Dr. Paliwal, one question?
Yes, please. Yes, please.
I'm Dr. Smita Joshi, senior anesthetist.
Okay.
Doctor, can I ask
Please.
her? Yeah.
Please start your video, ma'am.
Please go
Please
ahead.
start your video.
Okay.
Yes.
Sir, I'm
Good
Dr.
evening, ma'am.
Joshi. Good evening.
Good evening.
Sir, you said for PCNL, can we do segmental epidural with ropivacaine 0.75% and for the lower
Segmental spinal or epidural? Spinal.
segmental epidural? This is maybe little out of our topic, but I'm just asking you combination of two local anesthetics. What I wanted to ask you, for putting a DJ stent, can we use spinal chlorprocaine, and when the effect wears off, can we use the segmental epidural with ropivacaine at the thoracic level?
Can be used, but no need to have two techniques together for such a small procedure. If you use a simple single shot spinal, even at lower thoracic level, that is even enough for putting a stent and PCNL. These are the things you have to use two-drug technique when you are using very low doses at the thoracic levels, I mean lower thoracic levels. Otherwise, if you use a 2 to 2.5 ml of the drugs, then it usually involves the lumbosacral roots initially. Okay. And that is sufficient for a stent insertion. Okay, that wears off after 70 to 80 minutes. So no need for a dual technique in such cases. Many people are doing it in single shot spinal.
You're right. I just wanted to
Yeah.
ask you, can we combine two local anesthetics like this, one in
Yeah, yeah.
epidural, one in spinal?
Why not?
Because chloroprocaine wears off in 30 minutes and we
Yeah,
use
chlorprocaine.
ropivacaine.
What happens is chlorprocaine at lower levels, even lumbar levels, it spares lumbosacral roots. Being isobaric drugs, they take a little time for onset. So why not to use a single shot spinal at around T10 to T20 level with just 2 to 2.5 ml of the drugs? That will provide you sufficient levels for even stent insertion.
Yeah. So sometimes we are scared of making the patient prone with a higher.
And the patient can turn on his own. Actually, if you ask the patient to turn after giving spinal with isobaric drugs, they can turn on his own
Okay.
in prone position.
Okay. Thank you very much.
That is immediately after spinal, not
Yeah.
after DJ insertion. By that time, the effect usually sets in. Then you have to turn the patient. Like
Okay.
in spine surgeries, we ask the patient to turn immediately after spinal. They turn on in their own.
Right. That's a safety. Thank you, sir.
Thank you.
Thank you, ma'am. Sir, there is one question that while using two drug technique, are both drug given at same level?
Yeah,
Say
at same level.
T10. Okay.
According to surgery, you can choose your space and dose of the drug. Like for TLH, total laparoscopic hysterectomies, when you want to have if the surgeon can finish within 1 hour, then there is no need for two drug technique. You can just use your isobaric drugs with some additive, and that can be done with single shot spinal. The problem is if your surgeon is taking more than 1.5 hours or even more than 2 hours, then you can choose your drugs and additives according to your need. Like if you want to have an effect more than 2 hours, so use Dexamid as an additive. And that too in a different doses, like 10 micrograms can provide you a duration more than 3 hours with the same dose of isobaric drugs. If you use just rinse the syringe with Dextromid, it can provide a duration around 1.5 to 2 hours.
Okay, sir. How much volume is required to block one segment in with isobaric drug?
I already told you in my presentation, 1 ml of the drug spreads 2 to 3 segments above and below the site of injection. It spreads around 2 to 3 segments above and below the site. 4-5 segments, 1 ml is sufficient. Around 5 segments.
Yes, sir. As you
Accordingly,
mentioned,
can
sir.
choose.
Thank you, sir. As you mentioned, prior there is some legal issues such as acceptance. Legal acceptance are still pending there.
Yeah, legal acceptance is still. I don't know how it will be taken up, but as it is not in textbooks, so there can be some issues. But in indicated cases, it can very well be justified. There are many cases which I have done which were not at all fit for general anesthesia, bilateral pneumonia with sepsis and all. And if you do perforation, if you don't do it, they will take it to home and let them die. And I saved a lot of patients with this technique, avoided them from going on post-op ventilators and pulmonary complications.
Okay. What type of consent you take in this kind of patients?
With educated patients, I usually explain them, but if the patients are not literate, then just tell them about the minor things. If you scare them too much, then they will not allow you to give any sort of anesthesia, not even general or not even spinal anesthesia. So in broader terms, we explain about these things, that not to scare the patient too much.
Okay. Any specific sedative adjuvant you give when the patient is anxious?
I usually use my favorite combination, especially in lap surgeries, Dexkit, if there are inadequate levels. Otherwise, the drug which is used intrathecally, like if I am using intrathecal fentanyl, then I use the remaining fentanyl intravenously for sedation, or at times midazolam. The things which will not, hamper his respiration and all. Minimal sedation.
Okay. So for newly using segmental spinal people, if what major things you will suggest to look for their case management?
I'll say that you start using this with simple things like umbilical hernia, epigastric hernias. These are very actually simple procedures, open surgeries. You have to just give spinal at around T10 level with 1.5 to 2 ml of the drugs, and that is sufficient. You don't have to worry about anything about the levels. Even if you find the levels about TT, T3, T2, these are mostly a sensory levels. And hemodynamic fluctuations, depending on the patient's previous hemodynamic parameters, can have some fluctuations in initial 10 minutes, but after that, usually there is nothing.
Okay. And as there are many students who has been participated in this webinar, so if some examiner would ask them about segmental spinal,
That is a difficult question. The examiners, even the oldies don't, even I am old, but they don't agree to this thing. It's not to be mentioned in exams unless it is mentioned in the standard textbooks. This is, gaining acceptance in the last 2-3 years, and many people are doing it. Not only me, but
yes.
many
We are
people.
also practicing. We are also practicing.
But unless it is mentioned in the books, the examiners won't accept it. So it's not to be mentioned in the. If specifically asked for, then only you can say. There is a brief mention in the Hadzik and Miller's about thoracic segmental thoracic spinals, just single page, but they have not mentioned any details about it.
So Kamdar sir wants to, sir wants to say something. Kamdar sir.
I'm Dr. Kamdar. I just have 2 questions to both the speakers. One is, do you come across the problem of shoulder pain?
Yeah.
Because of course, my experience is very limited as far as the segmental spinal is concerned. I've just started for last 2 years, but we do come across the discomfort in the shoulder. So we always tell the surgeon to instill a bupivacaine near the diaphragm. And that most of the time it solves the problem and patient is more comfortable. That is one. And second thing is, do you always monitor with ETCO2 all your cases?
Whenever there are facilities, I usually monitor. Many places there is no ETCO2 monitor. And about the first question, if your levels are adequate, above T4, around T2, these are, pinprick level sensation, and autonomic, and this thing is 2-3 segments above that. The patients usually don't complain of shoulder pain. And there are few precautions you have to ask the surgeon to start with the lowest initial flow rate and initial intra-abdominal pressure, not more than 12. And then he can increase gradually both. Flow rate and this thing. And whenever you are doing it in the regionals, if they keep the pressures more than 14 and suddenly insufflate with a flow rate of 8-10, then patient can have some hemodynamic fluctuations and also shoulder pain. I have seen patients going in pulseless when there was sudden inflation of abdomen, even under general anesthesia. So it's not a question of spinal or general anesthesia, but can happen with both the techniques. So
Sir, how do you manage shoulder pain otherwise?
A little bit sedation. I use Dexcate as sedation if adequate levels are not achieved.
See, even poor sedation is also not advisable because it causes a lot of respiratory exhaustion, especially in laparoscopic surgery. So, as Dr. Paliwal said, if I'm using fentanyl as an additive, remaining 50 microgram, 25 microgram I will
Fentanyl can be used intravenously,
Okay.
or otherwise, if at all the levels are not very good and the patient is not comfortable, then don't hesitate to convert it to general anesthesia. Either I put a eye gel just to make the patient comfortable, or put in an endotracheal tube if required. If it is a long duration surgery.
It can also happen that unexpectedly the surgery has gone on for a longer time.
That can happen. That you have to anyway convert the patient to general anesthesia in that case. And most of the times, eye gel based anesthesia is sufficient for such cases.
Yes. So it's just what
said-
I am doing. I am sharing what I am doing. We are using 1 gram of paracetamol along with 2 gram of magnesium before inflating the gas.
Okay.
It's been observed that the shoulder pain has been reduced.
I would advise
The incidence is reduced.
You add 100 milligrams of xylocard and
Dr.
Yeah, that's
Rajesh,
what
your
I am
voice
doing
is very
for
low.
my
I would advise
paracetamol and xylocard. I am using for all my general anesthesia cases,
absolutely
not for spinal.
Dexamethasone, magnesium sulfate, and this xylocard.
To be very frank, I am scared to use magnesium sulfate without a neuromuscular monitoring. At such a peripheral setups, I don't use it. If at all, I use it just 1 gram in select cases.
Maya,
Yes, madam. Yeah, please.
sir, I have two questions. One is all these cases, tremendous work you have done. Has it been in the institutional level, or have you done a few cases in
There are
private setups?
There were few cases like diaphragmatic hernia and all in the institute. Otherwise, most of cases are from a private setup.
And regarding this TLH, you said many a times we have observed that the surgeons are quite adamant. I mean, they insist
Yeah.
on giving general anesthesia also. So
Yeah,
do you think with giving, I mean, at T10, you have given spinal, segmental, does it take care of the pain which the patient experiences? Because they usually go beyond 14. I have seen this. And you just cannot argue with them on the table. They want whatever conditions they like to have. So it's a
that is
very
one thing
difficult
you
and tricky
cannot.
situation. Yes.
That
And
is
you
one
cannot
thing
give
that
more
is beyond
sedation
our
also.
control.
Yes. And
Madam,
thirdly,
There are many surgeons who don't like regional. It's their choice. I even give them choice. You want general anesthesia? I can very well give them general anesthesia. But now what happens is I am specially called for cases which require only regional anesthesia. I mean, those not fit for general anesthesia, or they are scared to use general anesthesia for such cases, like for breast surgeries or for like that liver abscess, ruptured liver abscess, which was 4.9 grams hemoglobin. The surgeon was scared of using general anesthesia, so called me for that case. That was not my regular surgeon. I went there for that case only. So
for
these are the
cases, I think. And third thing is regarding this LSCS. Can we use it in, especially in morbidly obese patients?
Yeah, I have done one PPCM, peripartum cardiomyopathy, with just 27 ejection fraction. In that case, I used 1 ml of the isobaric drug, and that time I combined it with this thing, epidural.
Okay. And at
But you can combine the 2-drug technique.
And thoracic level T10.
Yeah, it was lower thoracic and not much high.
Okay.
I don't remember. It was T11, 12, around something. It was done long back, PPCM. That time I was not using 2-drug techniques, but you can do it in 2-drug technique. Just 0.5 ml of the hyperbaric drug and 1 ml of isobaric drug. That will not cause much of hemodynamic fluctuations and will provide you with adequate levels.
Yes, relaxation is what is required.
Yeah, relaxation will be there, and you need some lumbosacral involvement in LSCS, especially during extraction of the babies.
Yes, yes. Okay.
In that case, we use Dexcat as a sedation because Dexmed is found to be very safe during LSCS because of high placental retention. So I used Xkit that time.
The dose?
Dose very minimal, 0.5 mcg per kg of dexamethasone and 1 milligram per kg of ketamine mixed together. And out of that 5 ml, I just use 1 to 2 ml. And that was very minimal. Maybe around 10 mcg of dexamethasone and 10 milligram or 15 milligram of ketamine. That was sufficient.
Okay. Thank you, sir. And this appears very exciting, even though it's not in textbooks. But I think in future, this is really a boon in certain cases. Thanks a lot.
Sir, may I ask you one just simple
Yeah.
query? Like we have the protocol that after giving the spinal, we tell patient not to get up for 24 hours and take bed rest and all. And in your video, you have shown that your patient is like walking after 3.5 hours. So is it justifiable or
It
just
is
for
justifiable. These days there's ambulatory spinal anesthesia or daycare spinal anesthesia is in progress. There are many procedures we do. We send the patients with, especially with chlorprocaine use. Like my MTBTL patients, they routinely go home after 4-5 hours with chlorprocaine.
after 4-5 years only we can discharge them?
Yeah, MTBTL patients, laparoscopic when we do it, even after 1 to 1.5 hours, but we send them home after 4-5 years. And
Okay, what about
till
fluid?
date, no one has come back. Pardon, madam?
What about fluids? How many?
Fluids, they don't require. We ask them to take as early as within 1.5 to 2 hours. That was the old concept, that keep the patient sleeping for 24 hours.
Right.
Even for LSCS, we ask our patient to get propped up within 2 or 3 hours whenever the spinal is veered off, even with hyperbaric drugs.
Okay.
The problem with us is, as far as medical legalities are concerned, is we are not very statistics oriented. Now people like Paliwal sir and all doing so much of work, and if they really come out with statistics, I don't think it's soon. Even textbooks will have to accept this data. People have been doing it. People are scared to put it across because of medical legal constraints. But if we have robust data to present, I think any teaching institute also will accept it one day.
One thing is, people are doing cervical epidurals, thoracic epidurals day in, day out. Even the PGs are doing it. They are perforating the duras. That time, no one asked, how about accidental dural puncture during cervical? In the cervical spaces, there is hardly a space intrathecally.
People are more worried about tall injury.
Yeah, there are many. I have seen many people doing thoracic epidurals routinely. And no one asked them about this query, that what will happen if there is accidental dural puncture. And it's not like that they are not puncturing dura. Many times there's 5% incidence of ADP in thoracic epidurals.
Yes.
But still the incidence of neurological complications is quoted to be very low. Just because of these anatomical explanations.
Yes, sir.
In segmental spinal, is there any IV fluid requirement? How much to be given, or is there any specific role of IV fluids? Like you said, you can discharge the patient in 4 hours. So
that depends on the surgery. Actually, what happens for other intra-abdominal surgeries, we don't discharge the patient same day. Only these laparoscopic TLs or other minor diagnostic scopies. Otherwise, laparoscopic appendicectomies or these patients we usually keep for 2 days, because anytime they can have some issues. Previously, they might be in dehydration and all. So we treat them as usual. Only daycare procedures like diagnostic scopies, hysteroscopies, or MTBTL patients. These are the cases we discharge on the same day. Otherwise, even if they are mobile, we keep them for at least 1 day.
Wait.
And fluid intake is very early. I mean, as soon as they are able to take it. And catheterization is usually not required with segmental.
Not required.
Many patients, they usually pass within an hour or half an hour after the procedure.
And one more last question, sorry.
Yeah, you can ask, no issues.
In laparoscopic cholecystectomy under segmental spinal, if patient move like lower limbs or unwanted movements are there, so how to
No.
prevent that, or what to tell patient, or you keep them heavily sedated?
What happens is, if you use an adequate dose, like if it is not contraindicated to use higher dose like 2 to 2.5 ml, there is initial involvement of the lumbosacral roots. The patients will not move his legs initially, though initial 10 minutes you can see that his legs are moving, but after some time they will have some involvement, not complete, like bromage 0, bromage 3, but partial involvement is always there. And by the time you finish the surgery, the recovery is complete. So you don't have to worry about these moments.
So
no patient
we achieve the desired effect.
Yeah, only there is no dense effect. It is just a partial effect.
Yeah.
Patient can move only the feet.
Is there. Okay,
some involvement is always there with adequate dose. If you have used just 1 ml at lower thoracic level, then there may not be adequate involvement, 1 to 1.5 ml. But if you are using 2 ml, 2.5 ml, then there is involvement.
Yeah.
So you can adjust things accordingly.
Sir, there's also one question in the chat box. While using 2-drug technique, are both drugs given at the same level, say T10, then how to decide the volume of the 2 drugs? When you're using a 2-drug technique, on what basis you
depends
decide the volume?
On for what procedure you are using these drugs. Like for laparoscopic surgeries, you need to have levels right above T4. I mean, about up to T4, T2 at least. So you have to use lower thoracic space for giving spinal. And in that case, you have to use around 2 ml of isobaric drug along with 0.5 ml to 1 ml of hyperbaric drug to have a dense effect at lumbosacral roots. 0.5 ml of hyperbaric drug initially will cover the lumbosacral roots, and the 2 ml you are using will have a spread from T2 to L1. So you can decide accordingly. If it is for LSCS, so you may not need that much of drug. Just around T5, T6 level is sufficient for LSCS. And the volume required is also low in pregnant patients. So 1 to 1.2 ml of the drug can be sufficient, isobaric drug, along with 0.5 ml of hyperbaric drug.
Sir, one more question is there. How is the hypotension or the other sympathetic block effects avoided in cases like MRM with segmental spinal?
No, the low dose of the drugs usually have only a sensory block. And as I have already told you, because of the preload is maintained because of the lumbosacral sparing and less venodilatation in lower limbs, the preload is usually maintained. And that maintains this thing, even if there is a sympathetic block or cardiac fibers are blocked. Even then, these things are maintained, but you have to keep monitoring all these things. Till date, I have not required any patient to get intubated for such thing. I mean, high levels or no respiratory issues has occurred.
Okay, I think that answers the last question also, like how often these patients land up with hypertension, and what is the
This can happen actually. Hypertension can happen in any regional. I mean, it depends on the patient's initial parameters, initial comorbidities of the patient. And in these cases, you can select your drugs accordingly. You can combine it with epidurals if you want to use a very low doses to avoid hypotension. Then you can use epidurals along with segmental spinal. You can use epidural volume extension technique to spread the drug to wider segments if your procedure is not long, or use epidural top-ups to spread the segments you want to block. So you can choose your techniques accordingly.
Okay.
And if at all you have an accidental dural puncture, you can convert it to continuous segmental spinal. In the same way as Dr. Rajesh has said about the continuous spinal anesthesia at lumbar levels, you can convert this also.
Okay. Okay. Thank you, sir. That
Okay.
answers the questions in the, there's one more question. If only sensory, then how to get motor, which is required for surgery? I didn't get the, maybe.
For open surgeries,
Hmm.
I already told you, hyperbaric drugs are usually preferred in male muscular patients to have a good relaxation. Like I used for that volvulus patient. He was a male patient, young male patient, to have adequate relaxation. But if the patient is very morbid ill, already there is a lot of relaxed tissues, and these things don't matter. Relaxation is usually adequate in such cases.
Yes, sir.
So you have to choose the drugs according to your, patient, your need.
Hello.
Okay. Thank you, sir. Tushar, you can just take over.
Yes. I think all the questions has been answered very nicely and very patiently by sir. Thank you, sir, for such enlightening our knowledge and giving us light on this topic, which is very unknown for us. You have explained this very simply and practically in practical way also. You have shown us the videos what you were doing, and you were also entertained our questions which were related and not related to your topic also. So thank you very much, sir, and hope for the topic to be accepted in textbooks. So thank you, thanks at all, thanks a lot, sir. Now I would like to hand over to our secretary, Dr. Seema Suryavanshi ma'am, for vote of thanks. Thank you.
Okay. Thank you, Dr. Tushar. It's my privilege to propose the vote of thanks as the Secretary of Society of Anesthesiologists. I extend my heartfelt thanks to our today's esteemed speakers, Dr. Paliwal sir and Dr. Rao sir, who are national faculty and who have helped us today in making understand about these techniques, which are relatively new to us, or we have been comparatively beginner with these techniques. Thank you, Dr. Rao sir and Paliwal sir, for sparing your valuable time. I want to especially thank Dr. Rao sir also, who has agreed to give presentation in a very short notice despite of his very busy schedule. I thank all the delegates who attended today's webinar and took active part in the webinar. Thank you, Dr. Tushar, for a wonderful coordination. I would like to extend my thanks to Maharashtra State Chapter ISA for providing us with technical support, and thank you, Janika Technologies, for the same. Once again, a very big thank you from all of us to Dr. Paliwal sir and Dr. Rao sir. It was a really very enlightening topic for all of us. Thank you all.
Thank you very much for
Thank you,
inviting
sir.
me and
Thank
for
you,
patient
Paliwal
listening.
sir. Yes, thank
I'm
you.
very much thankful.
And thank you, Dr. Rajesh. Actually, I think he is in the OPD. Thank you so much. Thank you. And sir, your interaction on social media regarding various queries is really heartening. And most of the time we read your answers and your messages, which our members, they post on the group.
Today I did a case
Thank you
under
so much.
hypobaric spinal actually. That is another topic, hypobaric spinal.
Hypobaric spinal. Okay.
Today only I did a case.
Okay.
Continuous spinal, and I actually had 100 slides including all those things, different.
Okay. It was really a
Just
wonderful
to have
presentation.
limited
Initially, we were thinking this topic has been actually done by, I think, Latur or Nanded. They have done
Many
15 days ago.
places we have
Sir has given talk in
presented.
many places basically, but as usual, many of the people they keep on missing out the topics, and we wanted
Between my presentation, my phone was ringing. There's a call from Vadodara. I have a presentation this week at Vadodara.
Okay.
So the
Okay.
madam was
Okay.
calling me. So switched off my phone. I'll call her.
As usual, many people do miss out the topics, and so we wanted to have it for our, especially for our SAPC members who are also freelancers, and they keep on many of our members keep on trying these techniques. But the best to hear from the experts. That was our aim for this.
There's a first time workshop next month. Dr. Wagela has arranged a workshop at Navsari next month. Let's see how it goes.
Workshop on what, sir?
Segmental spinal.
That is what I was going to tell. We need to call you and show us the demonstration.
I am very much scared. I have not used to it. Live workshops, just presentation is okay.
Yeah, he has posted the message, I think.
On 13th of March in Navsari, there is a live workshop.
Okay.
Let's see how it goes.
Yeah, that's nice.
Yeah.
Anyway,
Dr.
thank you
Rajesh
very
is there,
much.
I think, OPD seeing the patients. He has
He's a
put
busy
his
man.
video off. Busy. And Monday being a busy day for all of us. There were 100 participants, and I think 30-50 members, they had joined YouTube also. So it was really a wonderful presentation, wonderful webinar. Thank you so much, sir. And thank you all delegates. Yeah, thank you. We shall close the meeting now.
Yeah, yes.
Okay.
Yeah, thank you, sir. Thank you. You can, Asima, you can end up the meeting.
Yeah, ma'am. Yes.
कोणता रे बेटा कोणता फोल्डर कसं तुला दिलं होतं ना मी मागे मग माझ्या फोनिक्स साठी होतं ते मला वेगळं पाहिजे फोल्डर पाहिजे असं हेच लागेल मला असाइनमेंट कोणतं हेच पॅक आहे बेटा Save folder.